Today we're moving to the sexual dysfunction side. This is something that I'm really excited and enthusiastic about whenever I'm seeing patients in the clinic or having discussions and having lectures. And so I hope that shines through, and I'm going to try and go through this in kind of a systematic way, because we're going to be discussing erectile dysfunction first, then we'll move into some of the more cutting-edge treatments for this, which you may have heard about, PRP or platelet-rich plasma and shockwave therapy, which you may have even seen advertisements online about. Then later on, we'll have two lectures, one on Peyronie's disease and then on ejaculatory disorders. So let's get started here with the erectile dysfunction portion of this: pills, injections, surgery, and more. I do have two disclosures. Boston Scientific and Coloplast do make penile prostheses, non-financial speaker. So we're going to be discussing and understanding the history and etiology of erectile dysfunction. Where does this kind of come into play? We're going to review the current therapies and then identify future goals of treatment. After that, we'll move on to the second lecture with the advanced treatments and newer therapies. So let's start with a definition of impotence. This is the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. So this definition first grew out of an NIH consensus statement in 1993. And so what it was, they came up with an index patient, right? We're treating a pathology, we have to apply it to an actual human being. It can't exist outside of a vacuum. So men with no evidence of hypogonadism or hyperprolactinemia who develop after a well-established period of normal erectile function, ED, that is primarily organic in nature. What does that mean, organic in nature? Well, ED can have multiple causes, right? It can be organic, which is vasculogenic. Is it you're not getting enough blood to the penis? Is it leaking out too soon? Is it a mixed component? Is there a neurogenic component? Are we not innervating the penis or the pelvis the same way? Is there an anatomic distribution of or disturbance that doesn't cause blood to flow correctly? Or are there hormone deficiencies? We heard a lot about that yesterday with testosterone. Or is it psychogenic? You see a lot of people around finals time, 19-year-olds, 20-year-olds who come to your clinic and they say, I've got the worst erectile dysfunction ever. And we're going to get through it, and it's a lot of coaxing because it's not necessarily an organic cause. So there is we saw this yesterday. This is a little bit of a different iteration of it. This is the molecular mechanisms behind erectile dysfunction, and there's a lot going on here. So we'll just talk a little bit about it. But you see, this big blue cell is a smooth muscle cell. And it's going to be the target organ or the target tissue for erectile function. And on either sides of this, we've got lots of protein kinases that are activating. And ultimately what happens is that calcium is then sequestered, so it's not acting on myosin and actin, which come together and cause normally your smooth muscle to constrict. So when you don't have that calcium, it relaxes and you get smooth muscle relaxation. Blood's able to flow into the penis and we see an erection. And we'll look at some of this erectile pathway a little bit more specifically and how we can target that to optimize erectile function. How does this work? So in the flaccid state, you have all this sinusoidal tissue, all this smooth muscle that's constricted, so the blood cannot run into it. Also at this time, the subtunical venous plexuses, or the veins, they're organized around the outside of the tunica albuginea. So these two pictures are representative of the tunica albuginea, which is either one or two of the paired erectile bodies in the penis. And so at rest, we have a little bit of norepinephrine running through the penis that causes all this to constrict. When you get an erection, that smooth muscle relaxes via the mechanism that we just talked about. Blood rushes into the penis. It then compresses the outflow, or it compresses these venous sinusoids. And so it's like running a sink, right? You turn on the water, and after some point, the drain can't overcome it, and you start to fill it with water. It's the same thing with blood. So let's look at the history of erectile dysfunction. As early as 2000 BC, Hippocrates was injecting sheep testes extract into men with an attempt to try and cure what they were calling impotence at the time, which is now kind of an archaic term. We use erectile dysfunction, but in the literature we still do see impotence. And fast forward another 4,000 years, and in 1980 we're starting to see that erectile dysfunction is vastly underreported. In 1985, we knew there was roughly around 30 million US men who had erectile dysfunction at a burden of $146 million to the healthcare industry. But what does that look like in 1985? How do we extrapolate that? Well, They were, in 1985, there were 225 million US citizens. The national debt was under $1 trillion. The McDLT was at McDonald's. And if we look at the Billboard charts, we had Wham, Madonna, and Foreigner. So this is to put this in perspective. So later in that decade, we see the Massachusetts male aging study. So we're looking at testosterone, we're looking at hormones, we're looking at heart health over a course of several years in a population of relatively healthy men in Massachusetts. And we see that ED is fairly prevalent. In 1992, the NIH convenes and we get that consensus statement on impotence that we just saw. And in 1996, we see the first guidelines for erectile dysfunction coming out of the AUA. In 1998, everything changes. Pfizer releases Viagra. It's the first PD5 to go on the market, and their stock goes through the roof. In 2002, we see the International Index of Erectile Function, and this is a validated questionnaire to see what sort of assessment we have and what sort of improvement or lack thereof we see with treatment for erectile dysfunction, because how do we classify this? A lot of it's subjective. I mean, we can look at objective measures. We can look at blood flow in and out of the penis. We can do a rigidity score and do biosthesiometry and look at sensation as well. But really, what does it come down to? It comes down to how the person's feeling and if they feel like they're getting an erection. So we do see this questionnaire that pops up. And there's quite a few questions on it, and it's kind of been diluted down to, and this is meant to, you're not supposed to be able to read this. It's just showing this global picture, because I know that's very small. But if we divide it up into the scoring brackets, there's erectile function, there's intercourse satisfaction, orgasmic function, sexual desire, and overall satisfaction. And so what a lot of us use in clinic is that IIEF 5 or SHIM, Sexual Health Inventory in Men, which is that questionnaire on the left, which consists of 5 questions. Are your erections hard enough to penetrate? Do you feel like you lose your erection too soon? Is it overall satisfactory, and so forth? In 2005, we see updated AUA guidelines for erectile dysfunction, and they've even been updated again as recently as 2015. And then in 2017, 20 years after Viagra goes on the market, we see generics coming out for sildenafil. So now these medications are much more widely available. It's not going to be $100 for a pill of sildenafil. You can get 30 pills of sildenafil for under $30 now. So what's going on with an erection? Let's go back to penile hemodynamics, because we want to see how these medications are working. So we talked a little bit about the relaxation of that sinusoidal smooth muscle tissue, but it's really, the hemodynamics is an interplay between the arteries, the veins, and the nerves that are located on the penis. They're on the dorsum, or on the back side of it, superficial to the tunica albuginea, and deep to buccal fascia. There's not going to be an anatomy lesson, but this is just to show you there's multiple blood supplies. So you can see going through the corpora, or that yellowish tube in the middle of the diagram, there's one artery, the cavernosal artery, which is going to bring most of the blood to the penis. There's also a dorsal artery that sits on top, outside of that tunical layer, and there's also a main spongiosal artery that runs through the urethra underneath. We take this into account a lot when we're doing surgeries, if someone may have had a urethroplasty or scarred urethra, or maybe we're trying to do some additional procedures that we'll talk about in a bit that may leave you with compromised blood supply. And we do have a lot of back and forth communication between these blood supplies with these helicine arteries that if you were to do an ultrasound, you could see some takeoff arteries here that do assist with erections. And so if we were going to do an ultrasound and look at the blood flow into the penis and categorize or characterize an erection, we might do something like this. So someone comes to your office and you give them papaverin or prostaglandin to induce an erection. Prior to the erection, you can see there's going to be 2 waveforms on the bottom. There's going to be a systolic and a diastolic. So it's the pressure pulse, right? It's getting the pulse of the penis. So we see this dampened systolic envelope prior to the erection. And there's minimal diastolic flow. Blood's flowing into the penis, blood's flowing out, pretty constant. After the injection, both the systolic and the diastolic both start to go up. You get blood flowing into the penis, and then they're coming out through those subtunical venules. But then after a certain point, the inflow is going to start to compress the outflow. We see that peak systolic rise, you get a widened pulse pressure, the end diastolic goes down, and you get an erection. Now, this can be pathologic if, this is how we also look for pathologies whenever we're doing ultrasounds. And this is based on this study that was done as early as 1992. The Northwestern Radiology Department looked at 175 men who had what they suspected to be vasculogenic impotence or erectile dysfunction. And they looked at the peak systolic velocities and end diastolic velocities. And the important thing that come out of this is that we get these two numbers, one for arterial insufficiency and one for venous insufficiency. So if we're not getting blood into the penis at greater than 25 centimeters per second, it's likely an arterial cause or an arterial pathology. And so we might try and treat based on that. If it's a venous insufficiency, then blood's leaking out of the penis at greater than 5 centimeters per second. And so that's going to be treated a little bit differently, maybe with a constriction band or even moving to surgery. Let's talk about some of the causes and comorbidities for erectile dysfunction because they're numerous. If you look at any medication and you go down the list of side effects long enough, you're going to see erectile dysfunction. Many of the causes can be attributed to vascular pathologies, diabetes, medications, pelvic surgeries or traumas, neurologic causes, endocrinopathies, and sometimes we just don't know. If we go back to the 2015 census, there are 15.3 million men in the US who have diabetes, and we know that diabetes can be a major player in the cause of erectile dysfunction, often even a heralding sign for diabetics. We know patients with diabetes and ED are less responsive to oral treatments. This can be, as we know, diabetes is a small vessel disease, so you get neuropathy in the hands and feet, and also the small vessels inside the phallus. In men with diabetes, ED is more severe and associated with a decreased quality of life, and it also is harder to treat. We said it's less responsive to oral treatments, but it's not just the erectile dysfunction. We also see changes in the sensation and orgasmic dysfunction as well. And in some patients, as we said, ED can be the presenting sign of diabetes. Some of the factors that can contribute to this are advancing age, the duration of the diabetic or poor glycemic control, vascular disease, diuretics, and heart disease. So if we move on to cardiovascular disease, we know that symptoms of heart disease can develop in as little as 2 to 3 years after erectile dysfunction. So this can also be a heralding sign. If I have someone who is under 40 who comes to me for erectile dysfunction, we're going to do a cardiac workup as well. So we're going to get lipids, we're going to look at their creatinine, we're going to check their blood pressure, because sometimes we see a familiar hypercholesterolemia that presents as erectile dysfunction. And at 50% obstruction of some of the small vessels like the penile artery, you can see signs and symptoms of erectile dysfunction. We heard a lot about this yesterday, so we won't belabor this too much. But we know there is a correlation between erectile dysfunction and low testosterone. Testosterone does upregulate synthesis of nitric oxide synthase, which can lead to some of the precursors for erections. And so if you have low testosterone, you can have decreased libido, sex drive, ED itself, fatigue, depression, irritability, lean muscle mass goes down, increased fat goes up, anemia, poor blood glucose control. And I think we really hit this hard yesterday, but low testosterone is a marker of overall health. So, we don't take an individual pathology as in a vacuum. We want to treat the whole patient. So, not only do we just look for the erectile dysfunction, in that case, we would screen with a low testosterone. Prostate cancer. Erectile dysfunction and prostate cancer are often mentioned in the same sentence. Sexual dysfunction after radical prostatectomy or a surgical treatment to remove the prostate can affect 1/4 to 3/4 of men. And even in the best hands, when the nerves are spared, you can see erectile dysfunction that can persist up to a year after surgery, and also up to 50% of men in radiation as well. Now, this is with the treatment, but also with the pathology of prostate cancer. In general, we can see changes in erectile function, changes in conversion of testosterone to DHT, and then also if the actual adenoma or the actual malignancy is growing into the prostatic nerves, that can certainly have a deleterious effect on your erections. So when we do a prostatectomy, we're going to peel the nerves off the prostate. They run on the lateral sides, and so oftentimes we'll try to brush those off and then just remove the prostate gland itself, and then suture the sphincter and the bladder back together. With that comes some temporary incontinence, and also on occasion temporary erectile dysfunction, or otherwise sometimes it'll progress to permanent erectile dysfunction. So let's go back to our picture of the functionality and the physiology of an erection. The tunica albuginea is that shiny, sheeny outer layer of the penis. It's formed with collagen. Now, if you get abnormal collagen laying down a scar tissue, collagen types 1 and 3, you can get what's called Peyronie's disease. And I tell guys, it's like if you're putting a piece of tape on a balloon and then you're trying to blow up that balloon, well, part of it just doesn't expand. That's because you've got scar tissue there. And so you get deviation of or curvature of the penis around that plaque, and that can also disrupt the outflow, the venous flow, leading to erectile dysfunction. So let's go into the therapies for erectile dysfunction. We've talked about what it is and how to classify it, but we know diet and exercise is always an option. There are type 5 phosphodiesterase inhibitors. That's going to be your Viagra, Cialis, or I should say sildenafil, tadalafil, vardenafil, and avanafil. Internet therapies are vast and numerous. If you go on social media, you'll see these kind of popping up all the time. It's really bad too if you are Googling things like this for work and then you have Siri and other things overhear you and then give you suggestions. Shockwave therapy, which we'll go into. Medicated urethral systems for erection, or MUSE, which is a urethral suppository. Intracavernosal injections. Vacuum devices. And then penile prosthesis. There's a 1, 2, and 3 pieces that are out there, and we'll talk a little bit about those. Let's talk about PDE5 inhibitors first. I think everybody knows the little blue pill that came out, sildenafil, in 1998. How do they work? Well, actually, let's go back. So there's also sildenafil, there's avanafil, there's vardenafil, and tadalafil. They all have a different half-life. Cialis, which is tadalafil, has a half-life of about 17 and a half hours or 18 hours, so it's going to last a little bit longer in your system. It's a little bit more lipophilic, so it doesn't really matter as much if you eat it or have as much of a fatty meal in your stomach. You can take it 1 to 2 hours prior to intercourse, and that can assist with erections. That'll be around 20 milligrams is the max dose, or you can do a 5 milligram daily, and that allows for a little bit more spontaneity. The other medications are going to be around 3.5 to 4.5 hours for their half-life, so kind of a shorter onset, shorter offset. If you have a cheeseburger or several glasses of wine, this might not be as well absorbed, and it's going to pass through you kind of like a sugar pill, so 30 minutes to an hour before intercourse on an empty-ish stomach. So the way that they work, if we were going back to this smooth muscle cell, it's going to target a certain aspect of the pathway. And this is very small, but this is where phosphodiesterase works. So the whole goal of trying to increase your nitric oxide synthase and your oxygen donors to your smooth muscle cells is to activate the pathway and conversion of GTP to cyclic GMP. And then that's going to activate a couple of kinases and then sequester calcium in the smooth muscle. And so that GMP is going to hang around until it's devoured and broken down by phosphodiesterase. And so we inhibit that to try and potentiate the effect of an erection. So this is also the reason why if someone takes a sildenafil, they don't immediately get an erection. There still has to be the desire, the stimulation, and the input. How effective is it? If we go back to the New England Journal of Medicine paper that came out in 2001, here we see this was in 1998, we see that men who previously were undergoing sexual intercourse and who did not take any of these pills might have the ability to perform satisfactory in 1 in 5 times. However, after taking sildenafil, and this bumped up to 4, sometimes 5-fold. So we do see it being effective. It does have several side effects, all the PDE5s. You can get cyanopsia, so it's very odd. You won't be able to look out and everything seems to have a little bit of a blue tinge to it. This is because of cross-reactivity of PDE6 in the retina. It's more prominent with vardenafil and sildenafil, but any of these medications, you can see some of the side effects popping up with the other medications. You can get flushing, headaches, nosebleeds, drops in blood pressure, which is one of the main warnings we have to give whenever we're starting men on this. Are you on nitrates for chest pain? Do you take nitroglycerin? If so, then you can't take this at all. If you were to take a sildenafil and you have chest pain within the next 24 hours, you go to the ER, they can't give you nitroglycerin. You have to wait 48 hours. Tadalafil, 72 hours. So some of these also cause reflux and dyspepsia. That's more commonly seen with tadalafil, and also muscle aches and back aches. And previously this used to be cost prohibitive, but now with more direct-to-consumer platforms, you see the advertisements online. There's numerous ones. It's going to be pretty cost-effective. I think for some of our patients, we can get 90 pills of 5 milligram tadalafil for $10. Medicated urethral suppository for erections. This is a urethral suppository. It's better known as Muse. It's alprostadil. It's placed into the urethra. It's a small pellet that looks like an eraser tip, and there's an applicator tip that delivers the suppository a little bit deeper down to the urethra. It dissolves over the course of 5 minutes. You can kind of rub it between your fingers to help it dissolve, and then 5 to 20 minutes afterwards, if it's effective, it'll induce an erection. And so our guidelines would say if we're going to give either the Muse or an intracavernosal injection, we do this in the office because we don't want to have an erection that lasts longer than 4 hours, or a priapism, in which case we'd need to give some phenylephrine to try and bring that erection down. Intracavernosal injections. These are what we often use in coordination with our erectile penile Doppler ultrasounds in order to evaluate the pathology. Is it arterial leak? Is it a venous insufficiency? The way that they work is going to be numerous. So if we go back to our favorite picture, it's going to work on multiple aspects. It's going to maintain high levels of cyclic GMP. On the other aspect of the smooth muscle cell, we have cyclic AMP doing the same thing, and so it's going to perpetuate that. And then there's also going to be an effect on just a direct agonist. So if we were to look at how this is broken down, and this is just a particular table from one of our local pharmacies, there are different medications that go into these intracavernosal injections. It can be one ingredient, which is usually alprostadil. It can be 2 ingredients, which would be papaverine and phentolamine, or it can be 3 ingredients, which will be all 3 of those together, the papaverine, the phentolamine, and the prostaglandin. Some men may find that with an injection, the prostaglandin is uncomfortable. It causes a burning sensation throughout the phallus, not just from the needle going into the penis, but the medication distributing amongst it. And that might be a reason that if someone were on a trimix, or all 3 of them, then we drop back down to a bimix, which would exclude the prostaglandin. It's not as effective, but it's also a little bit more satisfactory for the person using it. Now, there are some differences also in the administration. So if you have a prostaglandin, that doesn't need to be refrigerated. However, if you're having a compounded medication with either the bimix or the trimix, this is going to have to be refrigerated, so that can lead to changes in the ability to have some more spontaneity with these medications. How do we give them? Well, it's important to keep penile anatomy in consideration whenever we're doing this. We give the injection around 9 o'clock or 3 o'clock, 10 and 2 sometimes. But you really just don't want to go straight down because you can hit a dorsal artery or one of the penile arteries, cause a lot of bruising, discomfort, swelling. Or if you go at the inferior side and you go at 6 o'clock, the urethra is there, and the urethra is very vascular, and it very, very much likes to bleed. And so there are auto injectors too, because I think when we see this the first time, a lot of us are crossing our legs. But these auto injectors, you never see the needle. It's about a 21 gauge or smaller, so it just feels kind of like a small pinch. Vacuum erection devices. These work by drawing the blood into the penis. It's a negative pressure device. There's a tube that goes on the shaft of the penis, and there's a pressure regulator. So either with a handheld pump or a battery-operated mechanism, the air is going to be evacuated from the tube, and it will induce an erection. So this is great for men who have venous insufficiency because blood's leaking out of the penis. We can try and get all the blood in the world there, but it's leaking out. And I say that because these are often used with a constriction band. So there's a couple of different types that you can use. The best ones are going to be ones that are elastic or that are not rigid. If you have someone who uses a metal ring, or they get it from an online supplier, and it's not one that is approved for medical use, which many of these aren't, but you just have to make sure that it's not that it is elastic. They can get a penile strangulation injury, and that's when we're cutting them off in the middle of the night with a Dremel saw. Oftentimes the ring, but sometimes the phallus as well. So these work very well, but it's not always the most comfortable. Some men will discontinue use because it can lead to bruising, and it is what we call a cold erection because it's not going to be drawing persistent blood into the penis. And then we can move on to penile prosthetics. These are what we often will call the gold standard for refractory erectile dysfunction. It's not our first line. We can discuss it now according to our guidelines when someone comes into our office for the first consultation, but I would not recommend going straight to this because once we do that, there's kind of no going back. And we'll talk about it. But there are a couple different types of prosthetics, mainly with two different brands. There's one-piece or malleable rods, which can be placed into the shaft of the penis. There's a two-piece, which also houses a reservoir in the back part of the prosthetic, and there's a pump that cycles the fluid from that reservoir into the erectile bodies, giving an erection on demand, and then whenever the erection is no longer desired, it can cycle backwards into that reservoir. And a little bit more eloquently, and more often used, are these inflatable penile prostheses. And there's three pieces. There's a reservoir, which is going to go next to the bladder. There's inflatable rods, which are going to go into the actual erectile bodies of the penis, and a pump that goes in the scrotum. And so a lot of the evolution of these designs have occurred over the last 45 years with competition between some of these brands. And now we have a third one that's going to have a one-piece as well as a three-piece, which is going for FDA approval this year. So hopefully we'll see some more nuances and some more some newer technological advances in these devices. So how does it work? This is a schematic of the actual implant placed into the body. We can see the balloons replacing the erectile bodies. So they're actually going into the tunica albuginea. It's replacing that smooth muscle. So as you can imagine, it's hydraulics, right? So instead of having blood fill the penis, it's going to be salt water. The reservoir goes next to the abdomen and pumps in the scrotum. And we have a little video here, which is going to show kind of the overlay of it. So here we can see the device implanted inside the person. Whenever they're ready for an erection, they would pump up the pump. It's going to cycle water from that reservoir, and it's going to go into those balloons, giving a turgid erection that's suitable for penetration and intercourse. Then once the erection is no longer desired, there's a release button that moves a pin and cycles the water back into the reservoir, leading to a detumesced phallus. How effective is it? Well, they've been in use for over 45 years, and there's more than 500,000 men who've received a penile implant. And at 7 years, over 94% are still fully working. Oftentimes, the reason for mechanical failure is breaks in the tubing because of a lot of physical manipulation at the pump. There are risks involved. It is surgery. And with every surgery, not all patients are candidates. So one of the things we have to discuss is that it's not going to make natural or spontaneous erections or additional treatments possible afterwards. Because if we take this out, well, that normal penile architecture has been distorted, it's been destroyed. So we do have to keep that in the back of our mind. There can be mechanical failures, which can lead to revision surgeries, like we talked about. Pain, which is typically associated with the healing process. And so, we certainly want to keep that in mind whenever we're placing these, especially if it's in the outpatient setting. Men who have diabetes or spinal cord injuries or cutaneous manifestations of an infection may have an increased risk of infection. And this carries, the procedure itself carries a 1 to 2.5% risk of infection, and even more with a revision case at roughly 8 to 17%. And infection can be a very catastrophic and devastating outcome if one of these gets infected. It only takes a couple of bacteria, and you can't usually just put men on antibiotics because a biofilm forms over the device. It's silicone, and so once it's in there, it's like pond scum. You have to physically take it out and wash it out. So if we see frank purulence and have to remove it, then we're having to wait 3 months for the infection and inflammation to go down, which can cause shrinking of the phallus, scarring, Peyronie's disease, and changes in sensation. There are many subtleties to the placement of these devices. As you can imagine, surgeons like to try and change things up. We try and see what new ways we can put our names on things. And so there's different ways that we can place these in. And that might be according to a patient's anatomy or a surgeon preference. It can be placed penis-scrotally through a single incision at the base of the penis. We see the base of the corpora, and then we dilate those spaces up and put the device in there. It can be done through an infrapubic incision, so just above the phallus and below the pubic bone, a finger breadth or two, and we put everything in through there. Or even subcoronal, where we make an incision around the distal aspect of the shaft and deglove the penis and place it in that way, which is very good for concomitant surgeries for Peyronie's disease. The placement of the reservoir can be the bane for many surgeons. Whether we often place the reservoir through the inguinal canal, and so if someone's had a hernia repair or they have had, say, a prostatectomy or any other pelvic surgery, we worry about adhesions or bowel in that area. So we may go and place an ectopic reservoir, which is behind the oblique muscles, just in front of the transversalis fascia, or even retroperitoneal, and move it a little bit around to the side. And with anything too, everyone has with any surgery, we always have to consider antibiotics at the placement time, especially with a prosthetic or a new device. And everyone seems to have their own version of what antibiotics to use. And even our AUA guidelines were recently challenged in a paper last month saying that we should add some antifungal coverage. And we'll use oftentimes an irrigating device to try and dissuade any sort of biofilm formation at the time of implantation. Oftentimes we'll have people come to our office and say, what's the question that everyone wants to know? Can you make it bigger, right? Not yet. So in short, but there's a couple of different techniques that have been pioneered that we're still learning about that I think are interesting, and so I wanted to bring them up here. One is the sliding technique, and the other is the silicone sleeve. So you may have seen some of these. The sliding technique, it involves making a couple of incisions on the tunica albuginea and shifting that tunica to allow for a penile implant to be placed. When we do this, we have to lift the nerves off of the base of the penis because we are going to be distorting that anatomy. We spare the urethra, and so you can see on the picture on the left, it almost looks like a double L incision, and so those two aspects of the tunica are actually being taken and shifted apart, and then we're placing graft material to space the difference. And because we are distorting the normal that architecture of the penis with the sinusoids and the smooth muscle tissue, erections are going to be impossible without the assistance of a prosthetic. One of the things that we have to worry about with this is distortion of the blood supply. So in some of the initial series, you saw penile necrosis as high as 10% in some of these patients, which can be catastrophic. They're coming to you because they want to improve their erectile function and their prowess, and now they've got a necrotic penis, and you have to take it out. Silicone sleeve implants. These, I'm pretty excited about these. I have not done any of these yet. And time remains to be seen if I will be doing them. But it's a silicone sleeve. It's kind of like a hot dog bun. An incision is made either infrapubically or underneath or penis-scrotal, and the device is placed on just above the tunica albuginea, and it's sutured in. Afterwards, then the penis is then placed back into its normal position, and it's essentially placed on stretch by virtue of this implant. And so erections afterwards are going to be minimally excessive because the penis is already in an erect state, but it does add girth to the phallus. It originally started, it was FDA approved for one gentleman who is implanting them, and then we're starting to see a couple more implanters doing it now. So what does the future look like? We talked a lot about what we have now. Well, shockwave therapy, we'll talk about that here in about 5 minutes. Stem cell therapy, can we induce vasculogenesis and improve our neurofunction in the penis? Platelet-rich plasma, can we do the same thing with the body's own material? And then also advances in prosthetics. One of the companies used to be, before it changed and made mostly prosthetics, also did cardiac pacemakers. So the thought is, rather than having a pump in the base of the scrotum, why not have something like a battery that can be placed somewhere else in the body that can either take Wi-Fi, or you can pull up an app on your phone and change the turgor like you would change your flashlight. So there's lots of things that are in the works. Obviously, you don't want to connect to public Wi-Fi and things like that, but the options are vast, and there's lots of people thinking about these things. So we are excited about the future because, as you can imagine, you're here because you're interested in this, right? People are interested in this, and so that drives innovation and discovery. So in conclusion, erectile dysfunction, the etiology can be single or multifactorial. And there's a multitude of treatments ranging from non-invasive to invasive, and therapies can be offered and applied in a patient-centered manner. So I thank you for your attention.